Hello, I'm Lisa Martin from HORIBA Veterinary, and I'm delighted to welcome you to our next continuing professional development webinar. Our previous CPD content on a wide range of veterinary subjects can be found on the HORIBA Veterinary website in the support section. The address for this is displayed on your screen now. I'd like to introduce you to our speaker, tell you what to expect from the webinar, and a little bit about HORIBA Veterinary. We're very pleased to be working with Mark Bowen, a highly experienced practicing veterinary surgeon with a sustained track record in veterinary medicine, education and clinically informed research. Mark qualified from the RVC in 1996 and is an RCVS specialist in equine internal medicine with expertise and numerous publications in equine cardiology, diagnostic imaging and gastric disease. He has a Master's in Medical Education and is Principal Fellow of the Higher Education Academy. He's been awarded the status of Specialist in Veterinary Sports Medicine and Rehabilitation by the European Board of Veterinary Specialisation. Mark has close links with the Horse Race Betting Levy Board and is a Veterinary Advisory Committee member and is Chair of the Codes of Practice Subcommittee. He's a former BEVA President with a strong interest in the future of the profession and responsible medicine's use. He authored the Protect Me Toolkit for the responsible use of antibiotics in equine practice. Mark was awarded Fellowship of the Royal College of Veterinary Surgeons in 2016. How can we minimise the spread of strangles and limit its effects on equines and the people who care for them? Strangles is still widespread with over 600 recorded outbreaks in the UK last year. Pre-movement testing for Strep equi has become widely recommended, with livery yards requiring serology before horses arrive. However, as many have found, it does not prevent strangles outbreaks associated with new arrivals, nor are those results as black and white as owners would like. Mark's presentation will review how to use laboratory testing and vaccination in the development of disease-free status in different yards. It will consider quarantine, testing and the new vaccine. HORIBA Veterinary are part of HORIBA Medical, a well-established provider of laboratory diagnostic instruments for animals and people too. HORIBA Veterinary work with veterinary reference laboratories, educational settings and general and referral veterinary practices. Our product range includes handheld meters running single parameter tests, high-capacity automated systems and the first fully integrated in-house PCR testing system. Here's a brief introduction. Our Lacra Twin handheld meter range works in seconds and includes specific instruments for ionised calcium and electrolytes and can be used patient-side. HORIBA offer two systems for clinical chemistry testing. Our Pentra PC400 is a high-throughput wet chemistry analyzer suitable for larger practices and reference laboratories. It features capacity for 55 onboard assays for day-to-day testing and beyond, including electrolytes, inflammatory markers and acute phase proteins. Users can run a single parameter or use open channels to create their own fully bespoke profiles. The 120 VP analyzer works in minutes on whole blood samples with 15 predefined panels for comprehensive or targeted testing in all species. Up to 24 parameters are simultaneously reported. Specific concerns can be assessed and monitored via panels for diabetes, electrolyte balance, liver and kidney function, with additional tests for coagulation and inflammation, including canine CRP and feline SAA. Our new VG2 analyzer combines fast testing for blood gases, infectious diseases and a range of endocrine, reproductive, cardiac and renal markers. The Pocket Central PCR analyzer is an easy-to-use, compact, benchtop instrument. All steps of the PCR process are fully automated, do not require any additional specialist equipment and can be run by any trained member of the practice team 24 hours a day. Results are available in just 85 minutes, so no waiting for a lab pickup or for your results to be sent through, speeding up diagnosis times and aiding patient management. The Pocket Central test range includes over 190 assays for bacteria, viruses, parasites and protozoa, including small animal, equine, farm, poultry and aquaculture work. The Pocket Central enables fast and easy PCR testing in any setting. Should you have any questions for Mark or for the HORIBA team, please write your query into the Q&A box on the screen and we will cover as much as possible at the end of the webinar. If you would like HORIBA to issue you with a CPD certificate of attendance, please provide your name and email address in the Q&A box and we can send this on in the next few days. You'll also have our contact details at the end of the webinar for any further queries or if you're watching back. The event recording will shortly be available to view via the HORIBA Veterinary website and you'll be sent details to enable access for yourself or for any colleagues. So now I'd like to hand over to Mark Bowen to talk to us about Strangles, vaccination, serology and guttural pouch lavage, how to combine tools to keep strangles at bay.
Thank you, Lisa. As Lisa says, I'm going to talk to you. I've shortened my title for my slides to keep it a bit easier than I gave poor Lisa, but keeping strangles at bay is the theme of today. And thank you for joining us. I know it's always difficult to attend these at night, so they will also be available afterwards for those who want to. And if you are attending afterwards and you do have further questions, please feel free to reach out to Lisa and she'll forward the questions to me and give you my contact details. So why did I choose to talk to you about strangles? Well, I'm going to talk to you about some cases that I've been involved in over the last 10 or so years, some of which have been long-term projects that I'm still involved in, both looking at clinical management, but also I was a member of the Horse Trust's Science and Ethics Committee when we started some of the work that has led to the recent vaccine. So I have a real interest in that vaccine from a scientific point of view as well as from a clinical point of view, although I do admit that I have yet to administer it to a single horse, although other people in the clinics I work in absolutely have. So why are we also worried about strangles? Well, we're worried about strangles because it's often a headache for us. It's a headache in terms of both doing the diagnostic testings as well as interpreting those tests. It's a challenge to us sometimes in terms of therapeutics and, more importantly, the desire to not use therapeutics in animals that have clearly got a bacterial disease and convincing our owners they don't need treatment. And it's a challenge to us because of the epidemiology. And the more we know about the epidemiology, actually, the more we should be worried about these diseases and the slightly blasé way we've managed horses with strangles. Yes, we've worried about biosecurity and hand hygiene, but we've never really considered the zoonotic potential, both of Strep equi, Serovar equi, and Serovar zooepidemicus, and I'm going to talk a bit about that. It's a hassle for us in control situations. It's a hassle for us in those multi-owner yards, often with multiple veterinary surgeons, where everyone's giving a slightly different message in terms of how we manage these cases. So strangles is a headache for us as clinicians. But to owners, it's a cause of panic, and often completely over-the-top panic in terms of morbidity, the spread it will have through the yard, the very low mortality that it has, although I'm not saying we shouldn't be worried about that, but that mortality is well below the panic that the disease brings about. But there's loss of training, there's veterinary fees, and there's loss of competition fees, and the inconvenience of strangles that in some livery yards can become quite unpleasant and very difficult. And I've know owners who have moved livery yards simply because of the way they've been treated during outbreaks of strangles. So it's a big cost to owners. And although it generates us income, I think most of us would be quite happy not to have that income. So the costs come from managing clinical disease, managing these cases that you can see here with the nasal discharge in the times that they're most contagious, the costs associated with isolation and quarantine, the costs associated with PPE, although thanks to COVID, you can pick up some probably not very good, but very cheap PPE online very easily these days. But there's still all of the hassle associated with how do you go about introducing an isolation facility. And I'm going to talk to you about some of the challenges and the difficulty in a real life situation. And we try and pretend that actually it's easy. We can segregate these horses, we can put them into groups, and your job should be quite easy. These horses are going to lose days of work, and hopefully you're going to stop them going to competition. And then there's the cost of testing. And that testing, as Lisa's already alluded to, can cause us yet more headaches as we try and interpret numbers that probably don't mean very much, and also explain why, when we've said a horse has no evidence that it's likely to be a carrier of strangles, does it turn out to be when we do other tests. So I'm going to go through some of the basics of Strep equi, just to remind you that Strep equi, subspecies equi, is very similar to Strep equi subspecies zooepidemicus, but it does have some unique characteristics which are associated with its pathogenicity. But more recently, for the last 5 or so years, we've started to recognize that Streptococcus zooepidemicus, which is what I'm going to call it for short, isn't just a commensal, and it can develop and display superantigens that gives it many of the same characteristics in terms of pathogenesis as Strep equi var equi. So it can cause abscesses, it can have pathogenesis factors that result in abscess formation. It can have many of the same characteristics. So I think when we talk about strangles, we should be going back to thinking about strangles as a clinical syndrome of horses developing upper airway infections and abscessation of their lymph nodes. And although it's usually caused by Streptococcus equi var equi, remembering that zooepidemicus is not the innocent bystander that we once thought of. And importantly, as its name suggests, zooepidemicus, it is a zoonotic infection. Strep zoo has been a cause of respiratory disease and hemorrhagic lung disease in dogs. It's been associated with respiratory disease associated with infected waterways and swimming pools, and it's been associated with respiratory disease in people. Strep equi var equi is an occasional pathogen of people who are also immunocompromised for whatever reason. And therefore, we should take more notice of those potential risks to our owners, both of equi var equi and equi var zooepidemicus. And when we are aerosolizing and flushing all of these bacteria around the environment, we should just take note. Are there any dogs about? Because they probably need to be kept away. And also, could anyone be immunocompromised? Have we ever even thought to warn them of those risks? So I'm going to focus on equi var equi. As I say, most of this is combined between the two, certainly with those superantigens. But Strep equi attaches to the nasopharyngeal epithelial cells. It migrates through the mucosa, moves to the lymphatics, and then to the lymph nodes. And I'm not just telling you that because it's in all the textbooks. I'm telling you that because that will impact on your sensitivity of diagnostic tests in that early disease state. In that early disease state, you might not find significant numbers of bacteria from a nasopharyngeal swab, and certainly not within the guttural pouches or within the lymph nodes. So we need to be careful about timing of testing. Although it multiplies extracellularly, it creates these capsules which are resistant to phagocytosis through a number of proteins. And the SEM protein was widely used as a diagnostic test throughout the US. In the UK, we use the AC antigens because they're slightly more sensitive and give us better hope of differentiating between equi and equi zooepidemicus. And these pathogenicity factors result in abscess formation. Their ability to resist phagocytosis by neutrophils, but attracting lots and lots of neutrophils to the site brings about the pus that we see. They then rupture and drain, and then the animal will recover and develop often long-term immunity. And Strangles is very much a disease of the young horse. Now, that's not saying that older horses can't be carriers and they can't be involved in the spread of disease, but the specific disease of Strangles is typically seen in horses of 5 years or less. We've largely moved away from bacteriology for diagnosing Strangles because there are better techniques available to us, but bacteriology can still be quite useful. It grows in gram-positive cocci in chains. It develops beta hemolysis. It has a very unique mucoid colony to its appearance, and the colonies don't stick very well to the agar plate, so you can often shake them around. Many people are able to smell Strep equi, var equi as a very unique sort of yeasty type smell, which is different to zooepidemicus. We can confirm diagnosis bacteriologically using certain carbohydrate assays. Realize many practices don't do this, and that mucoid beta hemolytic colony is very typical and what most people will use diagnostically. You'll all have seen horses with acute presentation, and the thing that they will start out with is pyrexia and lethargy. And that will usually be about 3 days after exposure. It's associated with a pharyngitis and ultimately lymph node abscessation. And it can be any of the lymph nodes. Yes, we typically see, as we can see in this picture down here, the retropharyngeal lymph nodes the submandibular lymph nodes that are involved. But this is a good lesson in anatomy when they rupture out through their retropharyngeal, parotid, cranial cervical, or retrobulbar lymph nodes. And it can take anything up to 4 weeks, but they typically rupture within 7 days of development. They might rupture outside and we'll see them, but they will also rupture into the airway and typically into the guttural pouch, leading to this long-term carrier status that causes us so much problem. But cough and nasal discharge are those very characteristic signs. Now, all of us see horses that are a bit sick for a few days. They have a bit of a cough, they're pyrexic, and then magically, either with or without antibiotics, get better. And whether these horses have developed an effective immune response and are being exposed to Strangles for another reason, something that should always be on your radar in a herd environment if you've got large or several horses presenting just with low-grade infections. It's worth thinking, have I got a Strangles problem on this yard? Disease of the guttural pouch will usually start with empyema, so that's just pus in the pouch, and often associated with, again, a fairly foul-smelling, slightly unique-smelling nasal discharge. We talked about trying to train some medical detection dogs in the detection of Strangles, and we've got some people lined up who are interested in doing this, and then the reports of hemorrhagic pneumonia in dogs with Strep zooepidemicus came out, and then we sort of had to stop that plan because we couldn't risk exposing medical detection dogs to zooepidemicus, which a significant number of these horses might have either as a secondary factor or as a differential diagnosis. So we unfortunately canned that, and then COVID hit, and then colleagues in Germany trained these medical detection dogs to identify COVID, and the smell of the discharge, I have no doubt we could have easily trained dogs to do it had we not been exposing them to those risks. Remember, you'll get generalized airway inflammation. So the name Strangles is associated with the compromise to airway function. I've never had to put a tracheotomy in these horses. Usually they do fine. I have made them collapse when I've sedated a horse to scope that I thought would be absolutely fine, completely compromised its upper airway, and it did fall over, but it stood up again very soon after. But it's just something to bear in mind whenever sedating these horses. If they have a compromised airway, you may reduce what little reserves they have. Seen a reasonable number of these horses present with almost chronic empyema. So they haven't got to the chondroid stage yet, but they have such an inflammatory, infectious process going on within their guttural pouches that they go on to develop damage to the cranial nerves. And the most common clinical sign that I've seen is of dysphagia. And I've not had any luck with those horses, and I've treated them for weeks to months. I've put stomach tubes in them to feed them. We've talked about doing esophagostomy tubes for long-term feeding, but none of these horses, once they develop dysphagia, none of those have had a return to pharyngeal function. So I think that's a very poor prognostic sign. I've spoken to lots of other people who have the same experience with those. So I've already sort of mentioned this already, that from exposure to inoculation of the lymphatics, it could take anything up to 3 days, and then you might have an incubation period for anything up to 2 weeks. Pyrexia is often the first clinical sign, and you often only have a 24-hour window between the onset of clinical signs being pyrexia and the onset of shedding. And that's the real challenge. These horses can even start shedding before you notice any other clinical signs. And that's important in pathogenesis and important when we think about how are we going to stratify the risks of these cases. Usually within 3 weeks, they'll have developed an immune response, and by 6 weeks, they should have a complete resolution of clinical signs. But the data says about 10% of horses will become carriers, and they can shed disease for anything up to 2 years. They rarely develop clinical signs themselves with that disease. So I'm not talking about the chronic empyema cases now that can't swallow. These are the horses that are clinically normal and have inspissated, for whatever reason, non-active bacteria sitting in their pouch in those chondroids. They aren't a risk to themselves, but they do and can lead to exposure to other horses. And they can be an important factor in terms of clinical disease in naive horses that might be introduced to your herd. So in terms of diagnosis, the question is when do you need confirmation? And the answer is most of the time you're not going to do diagnostic tests on these horses. You're going to say the horse that looks like it's got strangles has got strangles. And I would encourage you to stick to that. We don't need to do diagnostic testing in this setting, except to convince people that you're definitely dealing with equi var equi. There's problems with doing that though. And the problems are there may also be some zooepidemicus in here, and zooepidemicus likes to grow. It's much better at growing than equi. Or even your abscesses in this pony may be caused by zooepidemicus. Goes back to the point I made before. This horse has still got strangles, still got abscessated lymph nodes. It's a highly contagious disease, whether it's equi or equi zooepidemicus, and this horse needs isolating and the horses need to stop moving. The risk, therefore, is if you do confirmatory testing, small number of times you're going to come back and you're going to go, okay, it's come back and it's not equi. Now what do I do? And that's when it becomes problematic. So if you're going to do this, please counsel owners, livery yard owners, that equi isn't the only pathogen, that these horses have got strangles, even if you can't identify the bacteria using those tests. And we've already talked about some of the challenges in terms of the window of diagnosis. So it might be, if you do a nasopharyngeal swab, there just isn't any in the pharynx at the moment. It might not be in the lymph nodes at the moment, certainly in enough parts to detect. So please think very carefully. In terms of diagnostics, as Lisa's alluded to already, I'm going to talk in some detail about serology. Remember, serology is going to take about 5 weeks post-infection or exposure before it peaks. In the UK, we use the AC antigens, and by using that, we have a better way to differentiate between zooepidemicus and equi, whereas with the SEM proteins, there often was some crossover. They're all measured by ELISA. It's a relatively quick test. That's only going to tell us about exposure, and it's great at a herd level. You can see I've got a problem in this herd. I've got some slightly horses that are being sick for a day or two, then they get better. I'm not having to give them antibiotics. They're probably already immune. Serology in that setting to say, yes, there's a strangles problem on this yard can be quite useful. But probably it guides you to think, we now need to do something about it. So at a herd level, serology can be really useful. The challenge is when it comes back to the individual animal. Then we can look at bacterial detection. So typically we would do that with culture. As I say, we've moved to PCR, and I'll talk about a little bit about PCR later on. And we have different techniques. So if you get the right window when you've got a large lymph node, you can probably do a fine needle aspirate from that lymph node. I remember going out to one of my first Strangles outbreaks as a new graduate. I was really excited. I soon wasn't, when there were 4 vets working with 56 individual horse owners, all wanting slightly different things. But anyway, I stuck a needle in this first horse thinking I'd get lots of pus out. The horse was quiet because it was sick. I don't need to sedate it. I'm just going to put a twitch on it. Anyway, I got whacked on the top of my head with the horse's mandibles. And they, as many of you will know, that really hurts. So I always sedate for fine needle aspirates if I do them after that. We can do nasopharyngeal swabs, and we'll touch on this again later when we talk about carriers. Doing nasopharyngeal swabs to detect carriers isn't very useful, but doing nasopharyngeal swabs in this acute stage is useful. So nasopharyngeal swabs in a horse that's got nasal discharge is absolutely fine. People have even talked about doing nasopharyngeal lavage, where you place a catheter, could be an AI catheter up the nostril, and then liberate some of the pus and essentially catch it in a sterile bowl. And then we've got guttural pouch lavage. This is not a good time to be doing guttural pouch lavage in the clinical case, because it probably won't have got there yet. But on the whole, we're going to rely on clinical signs. And this data is from the infectious disease surveillance system, which is now based at the University of Cambridge and funded by the Levy Board. Clinical signs are often the most important thing we go looking for. So nasal discharge, pyrexia, and lymph node enlargement, and you're going to get the majority of those horses that way. There's very few cases that just have 1 or 2 things, such as chondroids or guttural pouch empyema, as you can see in those individual spots towards the top of that graph. So I've gone through a lot of this already, but the test you choose in that active new disease is important. So aspirating a lymph node will be very useful if that animal has got, if it's at that stage of the disease where it is already in that lymph node. But it's not going to be useful earlier on. We can do a nasopharyngeal swab using a moistened swab, but again, the infection needs to be in the nasopharyngeal region. It can't be in that mucosal stage or we won't get it. So we'll get false negatives and false positives. So this is the ACOM consensus statement, and this is the first journal that really pushed this idea of doing nasopharyngeal swabs. You'll still get false negatives though, so it still isn't perfect, but it's found to be more sensitive than nasopharyngeal swabs. So this is where you use an AI catheter, put some saline up the nose, and then catch it in a sterile bowl. But remember, guttural pouch lavage is not a good technique to obtain a sample. Once you've got your sample, then PCR is going to be, whatever you find, PCR is going to be the best way and the quickest way to give you an answer. And there's no question about the use of PCR. It gives us the greatest sensitivity and specificity and gives us the quickest result as well. So PCR once you've got your samples. So we're going to rely on clinical signs, and then we come to treatment. And so treatment, again, is controversial. As Lisa said, I authored the Beaver Protect Me guidelines. I'm not going to stand here saying you should give all of these horses antibiotics. But also I'm not going to stand here and say none of these horses should get antibiotics. And it's absolutely appropriate for some of those horses to be treated with antibiotics when appropriate. So the horses with lymph node abscesses, hot poultices, draining the abscesses if necessary, certainly the submandibular abscesses, I always give them non-steroidals. They usually get phenylbutazone, but in smaller horses, and we see quite a lot of this in small ponies, I do quite like using meloxicam for those cases. We also don't need to worry about any half spot issues, and ownership can be complicated in some of those. So meloxicam, this is one of the times I quite like using meloxicam. Most of these horses, I won't give them antibiotics to. There are lots of myths about strangles. And one of the myths that is if you give antibiotics, you might prolong resolution of an abscess. You might stop it from bursting. There's absolutely no evidence to suggest that's actually the case. But I don't think antimicrobials are needed in the same way that a cat with a cat bite abscess doesn't need antibiotics once you've lanced that abscess. The infection will clear once it can drain because there are plenty of neutrophils in that area. Some people think that in early stages of disease, antibiotics are contraindicated because they might prevent natural immunity. Again, there's no evidence for that. If you've got a group of high performance horses that you can isolate and segregate and ensure they haven't come into contact, we'll talk about that a bit later. And if you've got some horses with early clinical signs, so if they're maybe pyrexic with rhinitis and pharyngitis, treating them at that stage may be beneficial. I'm not talking about metaphylaxis where I'm going to blanket treat the horses without clinical signs. There is no evidence that that's a good thing to do, and I don't think many people would do that. So have a think about when you would use antibiotics. As I say, I don't stand in front of you saying we should never use antibiotics. There are cases where I think they are justified or even essential, but will often be put under pressure from our owners to give antibiotics. We've just told them their horse has got a bacterial infection, and as a result of that, they're not eating. It's very difficult to argue with them about the need for antibiotics. I think the thing you can do is say, well, let's give some non-steroidals, be that flunixin or meloxicam, and if it's not eating come the morning, then we'll start antibiotics tomorrow. So if you can delay the onset of antibiotics using non-steroidals, in many cases, you'll be able to avoid them completely. But I do think there are times, and actually the ACVAM consensus statement concurs. These words come from there. So the severely infected horses with a very high fever that are sick, maybe they benefit from antibiotics before they've developed an abscess. The horses with respiratory distress, again, they probably do deserve antibiotics. And yes, you could put a tracheotomy in them, but all of us know that tracheotomies in horses in the field are not very easy for people to be managing. Horses with metastatic abscessation, so when you get spread often into the abdominal cavity of disease, and I've seen several abdominal abscesses in the last 18 months that have been associated with strangles, where we've treated them with long-term antibiotics. Doxycycline is often very effective. It's very good at getting into abscesses. We do also have the issue is, what do we do about isolating these horses? We had a long debate about hospitalizing a horse with an abdominal abscess that we had cultured strep equi via equi from. Do we still need to isolate this horse? There wasn't any in its pouches, couldn't find any in its respiratory tract, but it's got strep equi infections. Anyway, we didn't isolate it, and we didn't have any in contact horses develop clinical signs. We did barrier nurse it, we instituted good hand hygiene, everyone wore gloves, we wore overalls, but it didn't go into our isolation unit. I'll briefly touch on purpura as a complication of strangles. It's not very common. It's really bad news. They're probably going to die anyway, despite whatever you do for them, and probably giving them antibiotics is appropriate, although theoretically they don't need antibiotics. They're in an immune-mediated response to the antigens of the cell wall. There probably isn't much live bacteria about, but I think you'd be hard-pressed, given the appalling survival rate, not to treat these cases with antibiotics as well as their steroids. There's so little about survival of those horses. There's no guidance about what is or isn't appropriate. And then we'll talk about treating local infections within the guttural pouch later, but I treat those with local antibiotics. I don't use systemic antibiotics, although the consensus statement says you might use systemic cases. But what I wouldn't do is use metaphylaxis. So I would not treat a clinically normal horse with penicillin or doxycycline in the hope that it will stop it getting disease. And I think there's more than actually we should be doing more to prevent spread. There's also the point that many horses won't get disease. Many horses will already be immune to strangles. So I think handing out antibiotics as prevention is not indicated. I'm going to talk about vaccination in the face of infection using Strangvac in a little moment. So what about complications? We'll often see horses develop anemia, and in the vast majority of that cases, that anemia is short-lived, is associated with chronic or acute and chronic inflammation, and it goes away as soon as the horse gets better. In a very small number, we do have an immune-mediated component to that, and those would need to be treated with corticosteroids. They're a hemolytic anemia rather than a non-regenerative anemia, so are quite easy to differentiate on laboratory samples because you're going to have hemolytic-looking plasma. I'm going to talk a lot about guttural spread to the guttural pouch. I've mentioned neurological conditions, and on the whole, they're not good things. We've talked about abscessation to distant site. It's really rare. We don't know why some horses get it and not others. It's something that occasionally happens. Giving antibiotics doesn't make it more or less common. And then we've got purpura hemorrhagica, which is the most important of these complications, and I'm going to mention it very briefly. We'll come back to that. So in terms of purpura, it's a generalized vasculitis. It's a hypersensitivity reaction to one of those cell wall proteins. It's very uncommon, but when it occurs, it's very serious. As a result of the vasculitis, you get thrombosis in the small arteries, and you can get skin and muscle necrosis. It tends to be skin signs first, often along the ventral abdomen, sometimes around the muzzle, but you'll get petechial hemorrhages on mucous membranes, and these can progress quite rapidly. These horses need urgent management. These are a clinical emergency, although what you're going to do with them isn't very difficult, because you're going to give them, as we would expect for an immune-mediated condition, corticosteroids. And my preference is to give them dexamethasone, and I give them the top dose, so I give them 0.2 mg/kg IV. These horses are already prone to developing laminitis, but if we can't get on top of the inflammatory response, they are not going to survive. I'll give them non-steroidals as well as high doses of corticosteroids. I'll give them intravenous fluid therapy and try cold hosing them, massage, walking them out. But these horses do not do well. So if you see these cases, I would hospitalize them. I would warn the owners that they have a poor prognosis. So those are the complications. So we've come along, we've diagnosed Strangles based on clinical signs of one horse. And what does the levy board tell you to do? And actually all the guidance, they tell you to stop all movement of all horses for a period that lasts 3 weeks after the last horse has clinical signs and the presence of negative results. So as an absolute minimum, you're going to stop movement off that yard for 2 months. That's going to be an absolute minimum period of time that you're going to be stopping movement. That's going to be very, very unpopular. But that's what we should be doing. Whatever we do, we should be stratifying the risk. We should be identifying horses into 3 categories based on a traffic light system: red, where they have clinical signs or have recently had clinical signs and have yet to be shown to be free of disease; amber are the in contacts of those, and those in contacts, remember, have to go back 3 days before the onset of clinical signs. In the consensus statement, and actually most people talk about the green group being just those without clinical signs or in contacts. I think we should go further, and I think the green group should be those where we can document freedom from disease. And if your facilities allow, and if you have space, then you can move those green horses essentially into a subunit within your area, and you might get to move horses off the yard quicker. So if you can institute this from day 1 of infection, and you segregate those green horses, you test them all to show they don't have disease, they aren't carriers, then those horses can probably, if they don't develop clinical signs in those next 3 weeks, you could start moving them. But they have to be done in a completely segregated way. I'll give you an example at the end about how we did that in a group of several hundred horses a few years ago. We should manage the groups the same, so there should be common mucking out equipment for the red horses, which are separate to the amber and to the green. And if you can't do that, then the horses should be managed green, then amber, then red. In the large outbreak that I was involved in, we even made the staff wear the color overalls that associated with those horses. So everyone knew, I'm wearing red overalls, this is a high-risk horse. I'm leading this horse around because they might need to do other things, they might need veterinary attention, but it's a red horse. Everyone then knows that's a high-risk horse, and nobody's going to go up and talk to it. I say don't identify the carriers in an outbreak, but if you want to have a green group that you can document as being free of disease, you need to identify those animals as not being the instigators of all of this, because your carriers will be asymptomatic. And if you put those into your green group without knowing that they're carriers, then you will be spreading infection within your green population, and then you can't do what I just said, which is try and shortcut this process. So the idea of getting them out of quarantine sooner relies on identifying carriers sooner. And I'll go through that in the example at the end of the presentation. Remember, Strangles is a particularly resistant bug. So horses can shed it, so they're an important source of infection for around a month after infection. We've talked about carriers, but the environment is also important. It can survive in dirt and on fence posts for 3 days. We used to think it was a lot longer than that, but actually more recent work has said it's only 3 days that they'll survive in the general environment, but it will survive in water troughs for up to 30 days, and in ideal weeks for ideal conditions, so in slightly warm conditions, anything up to 9 weeks. So it's really important that you empty and clean water troughs. Outbreaks in the summer are relatively easy to manage. Switch off the water, don't let anyone use that water trough for a week. It'll dry out within 7 days of a hot summer's day, or 7 hot summer's days. Then you won't have any spread of infection. It will all just have died. You can refill the water trough. What about vaccination? So we've had various vaccines available to us. The new vaccine is very different to what we've had before, and it's different because this is not made from live bacteria, so it's not a whole bacterial vaccine. It's a protein-made vaccine, so very similar to the COVID vaccines. It's a modified protein vaccine that is delivered to give the optimum immune response. So it was all about sequencing the Strangles bacteria, identifying the most antigenic proteins, and then combining them in a vaccine to give us the best response. And although it doesn't have a market claim for annual vaccination, actually the data does support an annual vaccination claim. So after the V1 and V2, the first vaccine's 3 to 4 weeks apart, you get fairly good protection with annual boosters. So the data sheet requires you to do them sooner. And that's just about the way it was licensed. Within 2 weeks of the second vaccine, horses will have a good immunity. So clinical signs will be reduced in the event of exposure. And importantly, this is a DIVA vaccine, so you can differentiate infection to vaccination. So it's not going to give you a false positive. So the vaccine's been out for, I think, almost 6 months now. I think it's getting limited uptake, and there are challenges with that in terms of previous Strangles vaccines that then were withdrawn from the market after people spent quite a lot of money and a lot of hassle giving them through a submucosal route. So the public or the horse owners are a little disincentivized at the moment, but the vaccine technology is good. Do have to just briefly mention the complications. So heat, pain, and swelling was seen in the study for which they got their license, and swelling in a reasonable number of horses, especially after V3. So after the third vaccination, 20 out of 28 horses had swelling after the third vaccine. So we do need to be mindful of that. We need to think about when we're going to use this, and probably not giving it during the eventing season to eventers, or to in the racing season to racehorses, but thinking about how we can use it. One thing that's probably quite effective is once the horses had at least V1 and V2, they're probably primed and such that you could vaccinate in face of an outbreak. It's obviously not licensed for that, But what I shall do with my own horses is this winter they'll get V1 and V2 through the winter when they're not working very hard, and then should they ever get or be exposed to strangles, they'll get a booster at that point, and I'll hope it will be enough. But the license requires 6 monthly, 3 to 6 monthly boosters, which I don't think is going to be very useful. So my experience with vaccination so far has been limited, so it's been difficult to convince clients to have yet another vaccine. The marketing authorization is part of the problem with that, in that the need for such regular vaccinations. It's not as bad as the submucosal one. The place where I've had most engagement is after we've cleared a yard. So we'll clear a yard by doing guttural pouch lavage, and then we'll say, and now's the time to invest in this vaccine. Be mindful of these vaccinations, and we'll see what happens. As with any vaccinations, we're all going to focus on the worst cases, but I have had reports of horses developing quite marked reactions, but equally there'll be horses who develop quite marked reactions after influenza. So once we've got rid of the infection, how are we going to keep a yard disease free? And is that even realistic? And it will entirely depend on your yard. If you've got a yard where you're constantly changing horses, they're going to competitions, then keeping a yard disease free is difficult, but it is possible. But it does need a lot of work. Vaccination is probably going to be an important part of that, but it's not the only part. We can't just rely on vaccination. Vaccination is not ever going to be perfect. We still should be isolating new arrivals for 3 weeks. Irrespective of any other diagnostic test, they need isolating, because no diagnostic test is perfect. Even if you do guttural pouch lavage, they may have been exposed to disease in the week leading up to you doing that guttural pouch sampling. If you know they haven't, if you know a bit about them, if depending on their environment, that you might be able to say, actually, we don't need to isolate this. But on the whole, every horse should be isolated. We need to determine freedom from disease. We need to get rid of carriers, and we need to not allow carriers onto yards. And if they are carriers, they need treating. And I'm going to touch on that. We can use serology on a regular basis, and the BHS Scotland system for recognition of disease-free status use herd level serology to determine exposure. So if all of the horses on the yard have got low serology, chances are they're not being exposed to strangles. If all of the horses have got high serology, even without disease, you've got an exposure problem. We need to improve our biosecurity, and horse owners are awful. I mean, we're not great as equine vets, but horse owners are awful when it comes to hand hygiene and biosecurity. They go from horse to horse. They feed them from their hands. They don't even wash their hands from going from mucking out to having their lunch. Now, I am a horse owner, so I can say these things, but horse owners' basic biosecurity is very poor. It's equally as bad at competitions. You get show judges who go around sticking their hands in horses' mouths to check bit compliance, and they go on to another horse without washing their hands. We really need to be improving biosecurity if we want to really get to a disease-free status. I think one of the interesting things that's coming up are the use of thermal microchips. It's been a little bit of work done in terms of how accurate they are, and thermal microchips have been shown to be quite effective depending where they're put. So in the gluteals, sadly, they work least well. But the green area where we put microchips in most horses seems to work quite well for horses that become hyperthermic during exercise. So this is exercise-induced hypothermia. That's not really the same as pyrexia. There are a couple of little studies looking at microchips in other states, but they put these in slightly odd places where they were able to detect pyrexia in in horses undergoing castration, and with a fairly good level of precision. So this shows us the level of bias. It's about 0.5 degree different from rectal temperature. And then another study in terms of how sensitive are these for detecting fever. And unfortunately, they'd put these microchips percutaneously, not within the muscle, and they showed a very good specificity, but a limited sensitivity at low ambient temperatures. Nobody's done this yet using the same study design. Can I detect fever using a intramuscularly or ligamentously placed microchip? But these are becoming more and more popular, and at some point that data will be available to us as veterinary surgeons, and we'll be getting bombarded by yard owners saying, what are we going to do with this horse? It's pyrexic, or its temperature's up 50% from where it normally is. And that's the sort of information we can look forward to with advances in technology. They can embed these readers in feed troughs, in all sorts of places. That's the reason at the moment the studies have been based on percutaneous ones, because they wanted to read them automatically. So what about antigen serology? So I get lots of questions about antigen serology. They get put in front of me. What am I going to do now? I get asked from my colleagues. Either they've done serology at a pre-purchase examination or just before a horse moves yard, and it comes back and it'll be 0.3, so the bottom of the equivocal range. What are we going to do? Is it valuable? Can we tell anything from it? And is it useful for the detection of carriers? So in terms of that second question, is it useful for the detection of carriers? No, it isn't. So Andy Durham published a study in Equine Veterinary Journal. We published ours in JVIM. He had about 300 horses. We had 407. We both had the same number of carriers, essentially. So he had 9 horses that were carriers based on endoscopy. We had 10. Of his, 8 of those 9 were seronegative using the 0.5 cutoff, and 3 using the borderline. So the majority of his 9 horses, you would have said, were seronegative. All 10 of ours were seronegative using a 0.5 cutoff, and only 1 was borderline at 0.3. So the point of this is you cannot use serology to identify carriers. In our population, I'm going to show you this data at the end if there's time, 30% of our herd, so although these horses weren't seropositive, 30% of the herd were. So that shows you that serology is really useful for telling us at a herd level we've got a problem. But when we came to scope these horses, we thought, oh no, we've got 400 horses and 30% of them are going to have disease in their pouches, and obviously they didn't, only 10 did. So it overestimated our problem and led to some other useful findings. So what are we going to do? Well, if we get a result of more than 0.5, so more than the threshold, we should be telling yard owners, horses, that this horse has been recently exposed to an infected horse. That's all it means. It doesn't mean they've got infection. They might already be seropositive, or they may have good immunity and it's just boosted their immunity. So we should still isolate that horse for 3 weeks. We should probably repeat the serology in a couple of weeks' time, and if the titers are going up, then we should probably consider a guttural patch lavage. In that equivocal range between 0.3 and 0.5, again, isolate the horse, repeat it in 2 weeks, or do a guttural patch lavage. If it's less than 0.3, okay, we know the horse hasn't recently been exposed to an infected horse, unless it was yesterday or the day before, but it doesn't mean it's not a carrier. So we still need to recommend guttural patch lavage. I think the theme is quite clear there. I don't have much faith in this as a diagnostic test. As a profession, we've perhaps all become a little over-reliant on it, but now we know how inaccurate it is for detection of carriers, we really need to be promoting guttural pouch sampling. So what about guttural pouch sampling? Well, guttural pouch sampling is much better than nasopharyngeal swabs. So if I do nasopharyngeal swabs, I need to do 3 of them to get the same sensitivity as 1 guttural pouch lavage. And if I combine that with PCR, it's the most sensitive and reliable way for the detection of carriers. But we still need to remember there are times early in disease where guttural pouch lavage won't be as valuable. If, however, I'm doing a guttural pouch lavage, I put my scope into the guttural pouch and I see chondroids or empyema, that horse needs management. And I don't care what the results of my PCR are at that point. In fact, I don't even submit them at that point because it's just a waste of money. That horse needs its pouch treating. And then in a month's time, hopefully its pouches will be normal and we can go back to treating them at the time. If you're doing lots of horses, it's going to be time consuming. Do not scrimp on postage. The last thing you want to do is sample 10 horses in a day, put them in the normal post, phone the lab up the next morning and say, have you got any results for us? What results? And we lost, during our screening of 400 horses, we lost too many samples for us to ever go back to the routine post, and they all got sent special delivery. But we have something new available to us now, and that's practice-based PCR. And Lisa mentioned this in the introduction. The benefit of this is you'll get an answer in 2 hours. It's easy to perform. Now, I've done laboratory work, I've done PCR. PCR is not an easy technique. It takes multiple steps. You need to handle the tissue properly. You need to preserve the tissue, the sample properly. You need to extract the RNA. All needs to be done in a clean environment. The benefit of these practice-based systems is they are like a whole laboratory in a box. All you have to do is put the sample in there, and they do all the hard work for you. They extract the DNA, they amplify the DNA, they give you an answer. So people worry, and I was worried when these first came out. It's like, but if I go to Rainbow's laboratory, their PCR is in a dedicated room. Nobody else goes into that room. It's essentially a sterile room, and it has a flow hood like this. How can I possibly be doing the same in my quite dirty laboratory? Lisa knows where I'm talking about. Quite dirty laboratory where people are in and out all the time with samples, wearing dirty clothes. They might have mud on their shoes. All the things that in a conventional PCR environment would be big no-nos. How could that work? Well, they work because the moment you put the sample in, you seal it, it's a clean environment. So inside the machine is clean, and therefore it doesn't matter how contaminated your environment is within reason. I still wouldn't go and put these in the stable, although we have talked about doing exactly that. So we did talk about, let's take this to the stables, we'll get the answers within 2 hours of sampling them. So guttural pouch watches are difficult. They take time and they take practice. I had a final year student with me today, and she said to me, I can't get a scope into a guttural pouch. I said, today you're going to. So there's a few tips. If you don't put your endoscope into the ventral meatus, then it's going to be really difficult. This picture on top, this is what the view you get. So this is a guttural pouch probe approaching the guttural pouch almost straight on. That's never going to go into the pouch. This has gone up the ventral meatus. You need to be approaching from underneath, coming up in this direction, not in this direction. When you start out, use a metal probe. Don't try and cut corners by using catheters. and don't try and cut corners by looking across from one side to the other. With a bit of practice, you'll still get that. Once you've advanced your probe about 3 to 4 inches into the pouch, then you need to twist to open the pouch. If you can't advance your probe very far into the pouch, then it's got stuck, and you just need to wiggle the probe, wiggle the end of your scope up and down to try and free it, and then advance it. Just come back a little bit, wiggle it up and down, and try again. Once it's passing freely into the pouch, then that's the time you can advance your scope. Really important point. When it comes to rotating the endoscope to opening that flap, the person with the control body, the person with the controls, does that, not the person holding the scope. The person holding the scope is trying to twist like this. All they're going to do is get really tired. The scope's going to slip in their hand. If you've got the controls like that, you can just turn them like that. The scope will turn. So the student I was with today, that's what I made her do. She said, I'm not going to get into this pouch. And she got into the pouch in under 5 minutes. So it's all about being patient and then using the control body of the scope to open the pouch, not trying to twist it. Once you get in there, look around the entire pouch, look for the presence of disease, because if there's disease, come out and treat that horse. I use 20 mils of saline, but if you're only using 20 mils of saline, you need to hold the head up or it'll just drain out. I use 20 mils because I buy the little Iripods for ocular lavage, and they come in 20 mil vials, and I just use one per side. Put the 20 mils in, flush with 5 mils of air to empty your tube, go looking for the pool of fluid and then aspirate it. And you want to get 10 mils back. If you're not getting 10 mils back, try again and get another sample. And then combine them. You don't need to submit a left and a right side. You just want to know, does this horse have disease? You're suspicious that it doesn't, because if you think you are, don't waste the laboratory fees. So submit them combined, don't do separate, and you're halving your costs already. If the horse has got chondroids or pus in its pouch, it has strangles. And I don't care what the laboratory test says, it's got strangles. And we've already talked about the challenges of incorrect laboratory data. If the horse has got empyema or chondroids, the best way of managing them is flushing them. Flush and flush and flush until they're gone. Sometimes you won't get them out on the first day. I use tap water. I tend to use a Nielsen's catheter, which I'll show you in a moment. Use a Nielsen's catheter. I attach have an adapter, and then I attach it to the tap. Have the head nice and low so they don't aspirate too much water, and that works just fine. If you're going to use, we'll come back to using pump sprayers later. You can use dilute iodine, and if you really want to, you can use 5-litre bags of saline, but you won't put enough in to get all of the chondroids out. With time, you'll get most of your chondroids out. Already said, if the horse is dysphagic, the prognosis is poor, and you need to counsel the owners before you spend lots of money on those cases. So I say I use a Nielsen's. I've occasionally gone from a Nielsen's to a full stomach tube to get the bigger chondroids out, but because I'm using a hose pipe, I can get really high volumes. I said at the beginning we should be a bit more careful about these bacteria. They all have a zoonotic risk, and we should be at least aware. We should probably be making everyone wear at minimum face masks when we're doing this to try and reduce that risk. If it doesn't work, if you can't get all the chondroids out, then I put some antibiotics in. I put antibiotics in a reverse thermodynamic gel, which I'll talk about in a moment. Put that in three times over 3 days apart, and that will soften most chondroids. So even if you couldn't get them out on day one, you'll be able to get them out later. The most important message is to keep the scalpels away. Second most important message is to not use pump sprays. The reason for that is these are a great environment for Pseudomonas to grow. And if you leave them even slightly damp, you have a really high risk of introducing a pseudomonal infection into these pouches, which is horrible to get rid of. So I've only ever had that using the pump sprays where they weren't completely emptied, but I would much rather use fresh running water than I would use a killer spray, obviously with a clean hose pipe. So I prefer a Nielsen's catheter. I get them from, it used to be Arnold's. I can't think who Arnold's have been taken over. Chambers do a Mayer catheter, and some people use AI catheters. You just need to bend the tip. My videos aren't going to play here, so I'm going to skip through these. I might just see if, no, my videos aren't going to play. So just need to bend the tip and then pass them into the guttural pouch. And the advantage of the metal Nielsen's catheters is they're easy to get. You can advance a Foley catheter over them, and they will then go into the pouch. And with practice, you can place those without needing an endoscope at all. So, as I say, we had a large cohort of horses with a Strangles problem. I'm going to skip over the details of them, but we had 400 horses, and we predicted we were going to have 30% of them with Strangles. One Saturday morning, it was like, how are we going to manage this? And at that time, our standard treatment protocol was we would mix benzyl penicillin with gelatin. So we'd heat the gelatin in the microwave to get it nice and liquid. We'd let it cool a bit. We'd put the benzyl penicillin in, and then we'd infuse it into the pouch through the metal Nielsen's catheter, and then we'd hold the horse's head up for about 3 minutes while it's set. And it's like, if I've got to do that to, let's say, approximately 100 horses, that's going to take a hell of a lot of time. As it was, we had a massive team of vet students who helped us do the endoscopy and a lot of equipment. So I phoned a colleague who works for Bowen Pharmaceuticals, is actually the owner of the business, and I said to him, I know this doesn't exist, but I need a substance that sets at body temperature and is liquid when it's cold, because I can't be using the microwave all the time because it's just not going to be practical. And I realized that's magic, and we called it magic goo, and he came back within half an hour and said, okay, I've got your product, we'll do that, and we can put antibiotics in it. And that's when the idea of a reverse thermodynamic gel came. The real advantage of this gel is it sets within 60 seconds. So it sets with body temperature rather than melting with body temperature. It comes ready-made with gel. These videos are going to work. So this video is, the gel has just gone in. This is the Nielsen's catheter that we used to put it in, and you'll watch it. There's its abscessated lymph node, that big lump in front of you, and it's virtually set. It's almost set now, and you can see the bubbles are now stationary. It's not moving as we move the horse's head. The gel has now set, so it sets that quickly. A quick word of warning: if you put this, see, bubbles have completely fixed. If you put this through a traditional look-down endoscope that uses an old-style halogen or halide bulb, then it will set in the endoscope. So you know the ones I mean, the ones that make the scope get really hot. If you use that, your scope will be so hot it will set if you pass it down your scope. It's not the end of the world. Just cool your scope down, it'll re-liquefy, but it makes it very difficult to put it in. That's why I use these Nielsen's catheters. So Magic Goo is great for softening the chondroids. So after three goes or so, most chondroids have become so flexible you can flush them out. If there still looks like they're biofilm, I sometimes use acetylcysteine. Haven't had great success with acetylcysteine, and when we've been desperate, we have gone a little bit further than acetylcysteine and we've used Milton, so the same bleach that's used for sterilizing babies' bottles, and we used it in exactly the same concentration for sterilizing babies' bottles on the basis that if it was safe enough for babies, would probably be okay in the guttural pouches. We've done a few horses. Don't put the scope in the next day because it's very hemorrhagic and inflamed, but within a few days that subsides and the horses are fine. They're clinically fine with it. Whatever method you use, if you've put antibiotics in the pouch, you need to wait at least 2 weeks before you resample to show freedom from disease. And then a technique that's been around now for about 20 years has been fenestration of the guttural pouch. And the idea of this is it's a minimally invasive technique. You do it with a laser, and the idea is it promotes airflow. And if we can promote airflow, we're less likely to get an environment that's going to sustain infection. And the idea is you simply make a triangular cut up in that pharyngeal recess, and you allow the, it gives you, if nothing else, a great way to lavage them. And I'd much rather do this than do a standard percutaneous approach through a higher vertebrotomy incision to try and get to the guttural pouches. This is without complication. The incision just behind the mandible, I have seen so many complications with that technique that I wouldn't do it to my own horse. So I just want to give you a quick example. I'm only going to go through one of these because I've talked about the army cases and the challenges we had, although I will briefly show you the serology results. So this was still quite a large yard, 65 horses, multiple vets, and as often happens in here, one horse gets strangles, it goes on to develop distal lymphedema, and it's only arrived at the yard 4 weeks previously. Been isolated only for a week, but it had been clinically normal, had a serology before arrival. It had been treated in an entirely appropriate way, and being treated entirely appropriately, although being given antibiotics with TMS, which wouldn't be my choice. And this caused a massive outcry on the yard because all of the other horse owners got really grumpy about this fact this new horse had brought Strangles onto the yard. Eventually, we managed to get some movement restrictions in place, but sadly, the horse died, secondary to it. Obviously, was developing purpura with its lymphedema. 2 other horses started to show signs of strangles. They recovered absolutely fine. And then the challenge was which horse, or how did this horse bring strangles onto the yard? And obviously, the lady had lost her horse, but she was also barraged with hate mail because she had brought strangles onto this yard. And it's more than likely that there was a carrier on this yard, and this immunologically naive horse came onto the yard having probably not seen strangles before, and picked up disease from the carrier that was already there, developed strangles, and then went on to develop purpura. So I think that the point of this case is actually it shows the value of isolating these horses for longer. So had this horse been isolated for 3 weeks, it still would have been exposed. It probably still would have got the same infection, but it would have given us some security. But what really needed to happen was testing of all 66 horses to identify the carrier. I've talked to you a lot about the army cases, so all I want to do is show you the serology from the first 40 horses we did. So we thought before we go out and start guttural pouch lavaging 400 horses, we'll at least do serology so we got some idea of the problem that we were facing. And the point is, a lot of these horses tested positive on serology in these first two groups, but we only found 10 carriers. So this is a result of those 10 carriers bringing about infection. It is always worth thinking about the STEPS protocol. So it was developed with the Animal Health Trust and the British Horse Society. Since the Animal Health Trust have closed, Red Wings have really taken that on. It's a very simple and easy to use protocol for horse owners, and I would encourage you to make that available. So in terms of take-home messages, we absolutely can eradicate strangles and keep yards strangles free, but it's time-consuming and it's expensive. And although vaccination is going to be an important part of that, it's not the only thing. And personally, I wouldn't embark in a vaccination program until I knew the status of the herd I was managing. And that means doing guttural pouch lavages and testing for identifying your carriers. I think the exciting thing is we've got a vaccine at the same time that we are getting access to practice-based testing, where we'll be practically able to do strep equi testing in-house, and we won't have to be delaying results. So I've got the horse that the student scoped for me today is in a charity setting, and if the results come back negative tomorrow, it can go out in a herd with its friends and have a much happier life than it's been exposed to before. So what I'd like to do now is open the floor up to any questions. I'm going to stop sharing my screen, or they're going to do that for me. They are. And then.
Okay, thanks very much indeed, Mark. We did have a slight technical issue at the end there, that we couldn't see your slides after the probe placement, so we didn't get to see the serology slides, and we couldn't get to see the videos. But I'm sure that if anybody is super keen to see those, we can access them from Mark and can send them on to anybody that would like to see them. So apologies for the slight technical hitch there, but I'm sure that Mark's wise words helped with improving your knowledge about Strangles diagnosis.
The important thing about the serology was that 90% of horses had above the 0.3 baseline, so it was pretty scary.
Okay.
Actually, I'll make the slides available so Lisa can add them to the webinar for anyone wanting to watch again.
Okay, that would be fantastic. Thanks very much indeed. And thank you so much for the brilliant presentation, including all of your practical experience, everything from how to scope to how to identify metastatic abscesses, and also how not to get bonked on the head quite severely as well. So all of those things are very useful. There was an awful lot of information there. And as our attendees will know, that the video will be available to watch back, and also for anybody who wasn't able to join us this evening, they'll be able to access as well. So thank you so much for attending. We do have some questions that have come in, and we're able to take some more as well. So if you do have any questions for Mark whilst we've still got him, please pop them into the questions boxes now, and we will bring them up. And as Mark said, anything that's raised afterwards, you do have access to the HORIBA team. The details of that are on your screen now. And also Mark does work independently, so you'll be able to find him quite easily via the internet, or we can also send on any queries that you have. I also need to thank Mark very much for the kind words he said about the HORIBA PCR system. We did engage him to speak independently. We don't expect any product endorsements, but if anybody wants to know more about on-site PCR testing, then we're very happy to help you with that. So going to the questions that have come in, so thank you for those that have been submitted so far. We have, when submitting guttural pouch wash samples, do you always send for PCR and culture, or just one or the other? I've historically sent both, but have some vets in practice that just send for PCR. Thank you.
I just do PCR, but I do PCR for zooepidemicus and for equi because I I want to know if it's either, but I don't do culture as well. And it's often a time thing, and certainly with the moving horses situation, people want to get them moved as quickly as possible. What we were doing with the army horses, they'd buy 40 horses at a time, and we would want to screen them and get them into a field as quickly as possible. So speed, therefore PCR, and it would have been, we could have got the results the same day. Those horses could have arrived from Ireland, we could have scoped them, they could have gone out in a field if we'd been able to do it in-house.
Okay, okay, so...
I'm not going to say that. I genuinely think PCR is going to open up so many possibilities to us all.
Absolutely, you know, it is the way forwards, and as Mark's quite rightly said, historically you needed a molecular suite, you needed a biomedical scientist for running PCR testing. The system that HORIBA have, which you can see an image of on your screen there, the Pocket Central, the footprint of it is just a bit bigger than A4, so can fit into most practices and can be run by anybody. As Mark said earlier on, even a vet. Maybe you'd trust your nurses with it rather than a vet, but yes, it is super easy to use. So if anybody wants more details, then let me know. And yeah, within 2 hours you would have your results available. So very simple. And you would use your guttural pouch wash product, so just your saline that's come out from your wash, or also nasal pharyngeal swabs can be used too. So another question that's come in is, I may have missed it, but what is your view on PCR on NP washes for pre-movement rather than guttural pouch wash and rather than antibiotic bloods, ABX bloods?
So the challenge comes with nasopharyngeal swabs is they have a place. So they have a place in that early disease outbreak, but they're not going to help you find carriers, I'm afraid. So if they've got, so in the normal situation, they are as good as doing a third of a PCR. So you need 3 nasopharyngeal swabs to be as good as doing a PCR. In a horse that's got chondroids though, and it's not shedding all the time, you probably need more. So I would stress the value of doing guttural pouch washes. And I know people don't like doing them. I know they can be stressful. I know that sometimes you've got broken fibers on your endoscope and you struggle to find them. It is a case of practicing. I prefer to use a look down scope when I'm doing them myself. I used a video scope today because I had a student with me, but I prefer a quick look down scope because it's literally a 5-minute job with a bit of practice. We run courses through Beaver. If you've got a problem yard, reach out to a specialist. We'll come and we'll help you clear a yard and get you up to speed in doing guttural pouch washes. One of the practices that I work with a lot, we went out to do 6 in a day, and I did 5 while my colleague with a video scope did 1. And he said, how do you do them so quickly? And when I showed him that all he needed to do was twist the control body, he then did the next day, he went out and did another 6, and he was like, why has nobody told me this before? And it's simple tips like that. And that tip came to me from a supplier. It was, I don't know if people use them, but Cheryl at Burton's, she was like, what are you doing? Just turn the scope body, the control body, and it will follow. It's like, oh, you're absolutely right. It does, Cheryl. So we can get tips from all sorts of people, and they save us so much time. So if you have problem yards, somebody will come and help you. I'll come and help you and get you up to speed.
Okay, sounds like with the experience that you've had with literally hundreds of horses that you'll have had it honed to a fine art now, definitely.
Well, actually, I didn't do most of it. We took a group of, I think, 15 students with us into central London, and we would just go from horse to horse saying, yeah, you need to treat that horse. No, that one's fine. They did the work. And anyone can do this. It just needs a bit of time and practice, I promise you. However much you hate it.
Okay, thanks for the feedback, Mark. That's really helpful. We are going to be drawing to a close fairly soon. We're up to time now, but if there are any more questions to come in, then please do pop those into the chat and we can cover those now. I think that the evidence-based approach that you're able to present from having seen so very many horses and having to deal with so many owners as well, we know that there's quite a lot of stigma attached to Strangles outbreaks, and nobody wants to be the bearer of that particular piece of bad news. However, with good management, the outbreaks can be minimised and also prevented in the future with the use of the vaccine. So I've certainly learned a lot about the vaccine this evening. I haven't heard so much feedback. It sounds like there's still a lot of work that the company would like to do to get that out there. But Mark's got experience in using that so far as well in live settings. So just to point out, thank you very much to everybody that's been here this evening, that's joined us after their day at work. We also have to thank the HORIBA background team as well, who've also given up their evening. Our technical assistant is actually on holiday this week on half term. It wasn't the best bit of planning. But he's given up his evening whilst he's actually away on holiday to run the technical stuff for us. So thanks very much to Nick for that. We look forward to welcoming you to our next webinars. Mark has touched on some facets of responsible antimicrobial usage. Our next webinar, which is coming up in September, is completely focused around One Health and responsible medicines use. So we have speakers from the medical field, from small animal practice and from farm practice as well. So it's something that we are very keen to promote. So keep an eye out for details of our next webinar coming up in September. And we're also at commercial events later this year as well. We will have a stand at the BEVA Congress if you'll be there in Birmingham in September. And we'll also be at London Vet Show in November. So if you would like to come and talk to us, if you'd like to see the Pocket Central PCR Analyzer in action, you can see it there. If you'd like to see it sooner than that, get in touch. I can fit one in the back of my car and show up at your practice. We're very happy to do a lunch and learn if that's the kind of thing that gets your vets to come and have a conversation about it, or we'll do a breakfast meeting. I know those go down a bit better with equine practices. So if you have any interest, then please do get in touch and we can have a conversation with no obligation. So further questions we've had come in. Is it likely you might have a negative PCR and a positive culture?
No, that's quite unlikely. I have had it occasionally. It's quite unlikely that you would get that, and that would normally suggest you've done something bad with your processing. So we think the reason we got that is we'd cleaned the scope between horses, and we hadn't, in that particular case, we missed flushing it with water. So it's very unlikely.
Okay, I'd agree certainly from our side as well with PCR testing that the sensitivity is very good. Specificity may be more of an issue. So a false result is unlikely, but I can't comment quite so much on the positive culture results. A couple more questions have come in. Can Strangvac be administered into the gluteals or pectorals rather than the neck, and would this make swellings or pain easier to manage?
I think that's always one of those personal issues. I mean, I personally prefer vaccine reactions to deal with in the neck. Other people prefer in the pectorals. It's such a personal thing. I think you get less reactions in the gluteals, but equally a muscle reaction in the gluteals is going to have a much bigger impact on that horse's performance. So I don't have I don't have the experience of using it myself, as I say, but I would always go for the neck because that's where I do all my vaccines.
Okay, thanks for that, Mark. Okay, I think that's all of the questions that we've had so far. As we've already mentioned, if anybody does have any further queries, then please do get in touch. We're very happy to hear from you, very happy to help.
We've had a couple of thank yous as well. Great webinar, so thanks for the feedback on that to everybody who's given up their time this evening, especially Mark for putting together such an informative webinar for us. It's been a pleasure to work with him. So I will leave you all to enjoy the rest of your evening and stay safe. Thanks again.
Bye-bye.
Bye-bye.